Hi, my name is Devin Ritchie, and I am an LPN to BSN nursing student at Indiana State University. And today I'm going to give you a presentation about type 2 diabetes mellitus in pregnancy. So first, let's talk about the learning objectives of this presentation. So you as the learner, after watching this presentation, will understand the basics of type 2 diabetes mellitus. You'll understand the risks of diabetes in pregnancy. You'll understand how diabetes is treated during pregnancy. You'll understand the blood glucose targets during pregnancy, and you'll understand the A1C targets during pregnancy. So at this point, I'm going to ask that you pause the video and take the quick 10-question test that's linked in the description box below, and then go ahead and head on back when you're finished. So before we get started with the rest of the presentation, I wanted to go over a few definitions that will be helpful to keep in mind as we continue with the presentation. So the first definition is glucose, which a lot of times you'll hear people say blood glucose or blood sugar or sometimes sugar, but the actual definition of glucose is a simple sugar that is used as the body's main source of energy. And the reason people call it blood sugar or blood glucose is because we are measuring the amount of glucose in a person's blood. So therefore they refer to it as the blood glucose. Hyperglycemia, this means an abnormally high blood glucose. So like I said, that blood glucose, we're measuring how much glucose is in a patient's blood. If they have an abnormally high amount, that's called hyperglycemia. Hypoglycemia is the opposite, meaning they have an abnormally low blood glucose. Another definition that we'll talk about is postprandial, and this means after a meal, so something that occurs after someone eats. A1C is a blood test that measures the body's average blood glucose over the past 3 months. So type 2 diabetes is the most common type of diabetes, and it occurs when the body either doesn't make enough insulin or the body doesn't use the insulin that it makes properly. So insulin is produced by the pancreas, and it's what helps the glucose get into the cells so the body can use the glucose for energy. So if the glucose isn't able to get into the cells, the blood glucose is going to be elevated, causing hyperglycemia. So some of the risk factors of type 2 diabetes include middle-aged to older people, having a family history of diabetes, being overweight or obese, being African American, Hispanic Latino, American Indian, Asian American, or Pacific Islander, being physically inactive, or being diagnosed with gestational diabetes in a previous pregnancy. Some of the risks of having type 2 diabetes in pregnancy include a miscarriage, or otherwise referred to as a spontaneous abortion, having fetal anomalies, which is problems with the developing fetus, so it can have problems with the brain or the spine not developing correctly, preeclampsia, which is a hypertensive disorder in pregnancy that requires treatment in the hospital, fetal demise or death, macrosomia, which is an abnormally large baby, preterm birth, which means the baby's born before 37 weeks of gestation, neonatal hypoglycemia, so whenever the baby's born, the blood sugar is low, neonatal hyperbilirubinemia, and the baby can have an increased risk of obesity and type 2 diabetes whenever that baby moves into later childhood. So next we'll talk about treating diabetes in pregnancy. So the first way that it's treated is by glucose monitoring. So this is what is necessary for the doctors to make the decisions on how to treat the diabetes. They have to know what the woman's blood sugar is, and they ask that the woman check their blood sugar 4 times a day. So they ask that they check it fasting in the morning, so that's before they've had anything to eat or drink, and then they ask them to take it 1 to 2 hours after each meal, and then before bedtime, so 4 times a day. Another treatment is a lifestyle change. So how we had talked about some of those modifiable risk factors, during pregnancy you can still work on those modifiable risk factors, and you can do things such as improving your nutrition or becoming more physically active and managing your weight. So providers will tell women who have diabetes what their goal of their weight gain will be during pregnancy. The first line agent of a medication in to be used during pregnancy is insulin. And then the second line agent medication would be oral anti-diabetics. So those are glyburide and metformin. Those are the two that are used the most. Both of them cross the placenta, and they each carry their own risks. So glyburide has an increased risk of neonatal hypoglycemia and macrosomia, and metformin has a lower risk of neonatal hypoglycemia, less maternal weight gain, but could slightly increase the risk of prematurity. And then lastly, they're recommending that most women that have diabetes be on a low dose of aspirin, typically 81 milligrams a day, and that's to help with that risk factor of developing preeclampsia during pregnancy. So let's talk a little bit about insulin. So like I said previously, insulin is the first line agent to be used during pregnancy for diabetes. Insulin does not cross the placenta like the oral anti-diabetics that we had talked about. And there's 4 types of insulin that they could use. There's short acting, which has an onset of about 30 minutes, rapid acting, which has an onset of about 10 to 15 minutes, intermediate, which is an onset about 1 to 2 hours, and long acting, which some of them have an onset of about 1 to 2 hours, and some of them have an onset of about 6 hours. During pregnancy, the insulin will have to be titrated frequently, and that's by looking at those blood sugars. So that's why it's really important that women check their blood sugar during pregnancy so the doctors know how to titrate their insulin. So typically what they see is that in early pregnancy up to week 9, there is an increased need for insulin. So your body has a higher blood glucose, so you need more insulin. And then that kind of tapers off week 9 to week 16, and you have a decrease in those insulin needs. And then after 16 weeks, there's an increase again, and it increases about 5% per week. And then in your late 3rd trimester, it pretty much tapers off at that point, or in some women, they have a possible decrease in those insulin requirements. So when we are talking about checking your blood sugar, so these are the targets in pregnancy. And the reason why this is important is these targets are different in pregnancy than they are outside of pregnancy. So there also carries risks if the mom's blood sugar goes too low. So they don't want those blood glucose targets to be too low. So in fasting, they're looking at less than 95 as the goal. 1 hour postprandial, and again, that means after eating, so after your meal, they want it to be less than 140. And if you check it 2 hours after your meal, they want it to be less than 120. And A1C, which again, A1C is the test that measures the average blood glucose over the past 3 months. These targets in pregnancy change throughout a woman's pregnancy. So in the first trimester, they want those A1C targets to ideally be less than 7%. And then through the 2nd and 3rd trimester, the goal is to get that A1C less than 6%. So lastly, I have some resources for you, and I will link these resources in the description box below so you're able to access them. And these are from the NIDDK, the CDC, and the ADA, which are all really great sources for medical information. And these sources talk about diabetes, and then they talk about diabetes before pregnancy, during pregnancy, and then in that postpartum period, so after pregnancy. So I would encourage you to take a look at these resources to help you learn more. And at this point, I would also encourage you to go ahead and take that test again that you took in the beginning of the presentation, just to give yourself a little check on learning and see how much you learned. So I do hope that you enjoyed this presentation and got something out of it, and thank you so much for your time.